Hi, and thank you for tuning in to this webinar titled Spoiler Alert, Less is More, Drug Library Optimizations to Reduce Infusion Pump Alerts. My name is Sammy Burton, and I will be the moderator for this webinar session. I am a pharmacist by background and currently a medical science liaison with Baxter as part of the Infusion Systems team. Thank you again for tuning in to this webinar. If you are interested in other webinars or other educational resources, please visit our medical education website, News to Infuse, for more webinars like this one. Today, I have the pleasure of introducing our speaker for this topic, Kim Walker. Kim is the Senior Pharmacy Specialist in Analytics and Integration for Yale New Haven Health System. Kim is a pharmacist by background, having graduated from UNC School of Pharmacy. She also obtained her Master's of Public Health from The Ohio State University. Kim has really mastered the skills to be able to gain meaningful insights from smart infusion pump data, so I'm extremely delighted to hand it over to her to share her data analytics expertise. So take it away, Kim.
Thank you so much, Sammy, and thank you to everyone for joining the webinar. I hope you gained some valuable information about optimizing drug alerts that occur on your pumps. We'll start with some disclosures. I did not receive compensation for this webinar today. I am on an advisory panel for Boston Strategic Partners for AI technology in smart infusion pumps. However, I defer my honorarium for charitable donation. I am also a steering committee member of the National Infusion Collaborative. Jumping right into our learning objectives today, we're going to take a look at common drivers for infusion pump alerts. It's really important to know what is causing the alerts, and there's a couple of key things that you can always check out. So we're going to put that on your radar so that as you assess your own drug library, you can have these tools and these known factors to think about. Then we're going to take a look at the data. You can actually use some of the data that your pumps are collecting every single day to identify optimizations and try to reduce the number of alerts that are firing on your pumps that could be contributing to fatigue alert. Then we're going to talk about methods to assess the effect of those implemented changes, because one of the things we want to know is, did we do a good thing? We sought out to reduce alerts, we wanted to reduce nuisance alerts, but did it actually work? So if you don't follow up, it's kind of hard to know sometimes. So I'm going to give you some tools to use to be able to know whether or not your changes were effective. So why alerts? We all know about alert fatigue, which is desensitization to safety alerts resulting in ignoring or failing to respond appropriately to warnings. Two primary contributors to alert fatigue are the sheer volume of alerts that clinicians are exposed to and the overwhelming amount of evidence indicating that the majority of those alerts are clinically inconsequential. They're nuisance alerts. Unfortunately, in the process of dismissing insignificant alerts, critical warnings are also overlooked, with potentially devastating costs, including patient mortality and harm, extended hospitalizations, litigation, healthcare worker burnout, and broken trust in care delivery. In 2015, the Joint Commission issued a Sentinel event alert, acknowledging the dangers of alert fatigue and recommended adopting a culture of safety, including careful review of implemented technology to minimize alert exposure. For the past few years here at Yale New Haven Health, we've had a system-wide initiative to reduce the number of alerts from any and all technology by 50%. One of the many technologies that was reviewed as part of this initiative was pump alerts. So why pump alerts? Why these alerts? Historically, in our institutions, we have followed alerts and alert override rates internally for our large volume fleet. This information is reported quarterly to our System Smart Pump Committee, as well as the system safety stakeholders. In early 2024, when I was asked to evaluate alerts, I started with known data from our large volume fleet because it was readily accessible. We had recently also joined a collaborative that allowed us to see aggregated national level infusion data. When I compared our performance to the benchmark, I quickly realized that we had some work to do. So if you take a look at what I discovered on initial look, the bottom of this chart is the alert rate overall. And you can see us in the blue there. Our alert rate averaged between 10 and 11%, where the national benchmark is more like 7.3%. So we were doing worse than the national average, which is not something we like to hear here at Yale New Haven Health. Not proud of that. At the same time, our override rate was consistently between 82 to 84%. So that means that 82 to 84% of times, clinicians were accepting the breaches that they were finding in the pump library and overriding it and accepting the value. And that's compared to the national benchmark of 66.9%. So I knew that there was opportunity here, but then we had to figure out how to go about identifying those opportunities. Before we identify the opportunities, I want to take a moment and pause to talk about why these alerts fire. This is our first objective for today. It is very important to understand what could be driving your alerts because that helps you to know how to potentially address them in your drug library. At the most basic level, alerts fire on an infusion pump because a program parameter has been breached. The parameter may be a rate, a dose, a concentration, duration, or volume that is too high or too low compared to the allowable limits in the library. Soft limits can be overridden by the clinician on the pump and will be our primary focus today. Hard limit alerts force the user to back up and select a different parameter. The parameters in a drug library are generally not arbitrary and are often determined by multiple factors, including patient safety during infusion administration, alignment with practice and organizational policy, manufacturer recommendations, and the practice setting. At Yale New Haven Health, before parameters are finalized in the drug library, they've been reviewed by multiple pharmacists to ensure safety is promoted while efficacy is supported. They've also been checked for alignment with our EHR, alignment with drug use policy, and practice guidelines or protocols. Yet after all that effort, we still had a below average overall alert rate of 10%. Over the course of this journey, we identified quite a few factors that potentially drive alerts that I'd like to take a few minutes to highlight. Although our focus today is going to be on reducing those insignificant nuisance alerts that we know account for the majority of all alerts and lead to fatigue, I do want to briefly revisit the Joint Commission recommendation we touched on a few minutes ago. It encourages healthcare organizations to minimize alerts, specifically insignificant ones, so that significant alerts will be more prominent. Human error and real potential for patient harm are legitimate alerts that we want. When you start to investigate and identify potential opportunities, you may conclude there is no actionable target because the alert is legitimate and the library is actually doing what it is designed to do. In these situations, it's always appropriate to assess the alert to ensure that it's robust enough. I'll show an example of how we did this. Drug library complexity can take many forms, from naming of care areas to differentiating dose limits with modifiers, and even the number of drugs that are available to select. The goal is to develop a structure that is clear and generally only allows for one path to the correct entry for a given order. If you especially are in a larger organization with multiple delivery networks, maybe clinics, different specialties, you know that organizations are dynamic and constantly changing. There's always new personnel, new trainees, and evolving evidence. So that's where practice preferences can come in. Sometimes alarms occur because individual or group practice preferences are not aligned with the library. It may also be that new evidence has emerged that your frontline staff is integrating into practice, but has not yet been reviewed by the appropriate clinical stakeholders, such as your pharmacy and therapeutics committee or your drug use policy team. Alerts can also fire when the allowable parameters in your EHR do not match the parameters in your library. The same is true for any drug use policy or infusion policy that is not aligned with your library. Often this happens when changes to either the EHR or policy were approved and made, but didn't get communicated to your library owners. The owner making the EHR or policy update may not be aware that the change will affect the pump and does not realize communication is needed. These alerts are the very definition of nuisance. We hope that even minor inconsistencies like this will be reported, but if you utilize voluntary error reporting in your organization, you are likely aware that underreporting occurs for all events in the voluntary system, but especially for minor events, such as an alarm that fires because the pump isn't aligned with the EHR or with the treatment protocols. These two categories are perhaps where your pump data can have the biggest impact to drive proactive optimizations to reduce alerts. So now let's talk about how we can identify these alerts. We know some of the things that could drive them, but how do we go about starting to parse through the information to get to actionable optimizations? We'll take a closer look at what the pumps can tell you about your alerts through the reports available on the gateway in the next few slides. Utilizing the data directly from the pumps is the most proactive way that you can identify potential alert optimizations, but there are also other avenues. As mentioned, it is very common for healthcare organizations to have some form of voluntary error reporting system. Some may be utilized only for patient harm events, but they can be utilized for any event error, including nuisance alerting. If you are responsible for managing a drug library, it is worthwhile to coordinate with an error reporting system stakeholder and engage in regular review of pump-related reports. They may directly or indirectly indicate that an alert is an issue that needs to be evaluated. Finally, you can always solicit frontline feedback. It's really important for your library owners and your pump team to establish those relationships throughout the system with frontline resources, including nursing, your providers, and anyone who interacts with the pump as a user, so that you have open channels of communication. They will directly tell you what their pain points are, and it's often very useful and very insightful. Let's go back to that gateway reporting. There are reports available that you can use to proactively assess alerts that are occurring in your system. They are divided by the alert type, so soft or hard limit breaches, as well as when the alert occurs, whether it's during the infusion, a bolus, or a loading dose. We will not look at each of these individually today because how you utilize these reports will largely be the same. One thing to keep in mind, specifically with the hard limit reports, is that override and pullback information will not be present on hard limit reports, since pullback is the only option with a hard limit breach. This is a mini tutorial for reference on setting up your report and exporting the data. To really dive into the alerts, you generally need to run the report and export the details so that you can use software like Excel to pivot, analyze, and visualize your findings. This example is the soft limit report, but the process is generally the same for all of them. Start in box number 1 by defining your report parameters. When proactively looking for opportunities, I leave the drug field blank so that I can see everything. For my system, we like to look at a monthly or quarterly data. This time frame is up to you, but I would recommend a minimum of 1 month so that the trends you identify are more likely to be actual. Looking at a smaller period of time might highlight intermittent issues that aren't really true trends. For example, it's new graduate season right now for both nurses and residents. There's a lot of new trainees learning these technologies. So we expect increased alerts right now. If I were to look at a 1-week data, say in June, it is likely not at all accurate due to the influx of new caregivers. Once the report runs, there will be a graph on screen, and this brings us to box number 2. In this case, it'll be a pie graph of all soft limits with the override versus pullback rate. We need more than that. So click on the summary in step 2 and then scroll all the way to the bottom of your screen so that you can see the total counts shown in step 3. These are all hyperlinks. Click on either one of the hyperlinked total count and a detailed summary report with every infusion will populate on your screen. From here, if you scroll to the bottom again, you can export the detailed report to a CSV file. This is what you want because it provides care area, modifier, drug, and alert type information that you need to determine why your alerts are firing. We have our reports. Let's talk about how to use them. All you really need is Excel or any software capable of working with spreadsheets. You will need to be able to pivot your data, and if you prefer to interpret your data visually, we need to understand some techniques for generating charts. We will not go into step-by-step technical detail on how to produce the pivots and charts you will see, but we'll provide Excel techniques used to help guide you. We are going to look at 5 examples from the factors affecting alerts that we just reviewed, so let's dive right in. Our first use case here is bolus hard limits. And this, again, is actually an example where we recognize the need for stronger alerts due to voluntary reporting indicating staff were confused on which dose units to use for boluses. So should they use a calculated dose in milligrams or should they use an order dose in milligrams per kilograms for something that was weight-based? While this particular pump does allow for bolus units to be different from the infusion rate units, so we could have a bolus in milligrams when the rate is in milligrams per kilogram, for example, it doesn't mean that it's always clear to the clinician which one that they should be using. In this case, the issues were further complicated by many factors, including the fact that the EHR displays both the ordered dose, so in this case, a weight-based bolus in mg per kg, as well as the calculated dose, so the final dose in just milligrams. We also had disagreement with our physicians that use the pumps and nursing. Nursing is almost always referencing orders in the EHR when programming the pump, so they may reference either the ordered dose in mg per kg or the calculated dose in milligrams. Physicians, however, when using a pump, were often doing so in an emergent situation or in a procedural area and simply knew what dose they needed in mg per kg and were not usually thinking about calculating the dose before entering it on the pump. To identify this opportunity, we took the bolus soft limit report and pivoted the entire data set to identify the types and total alerts that were firing. This helped us determine whether we should target dose limits or time limits. Given the 99.2% override rate, we identified a need for hard limits instead of soft limits. We also noticed most overrides were for the bolus dose, but about 1/3 was still bolus time. We recognized that placing hard limits on the bolus dose would also naturally limit the bolus time, so our focus became on dosing. We opted, after multiple discussions between nursing and our providers, to use the ordered dose units for boluses and set hard limits to prevent calculated doses from being inadvertently entered. And that was our recommendation to system stakeholders ultimately, to implement hard limits for all bolus doses throughout the library. Our next use case is IV fluids. This points out how practice preferences may not align with your drug library, leading to alerts. This particularly was an issue with boluses, although the entry that it affected in the pump was actually our IV infusion entry. For a little background on the library build, we have historically placed a soft upper rate limit of 250 mL an hour on our IV fluid infusion entry, while enabling and allowing the bolus to be up to a max of 999 mL an hour, which is the limitation of the pump. The rationale here was safety. The thought was that the alert would prevent programming a bolus rate that prompted a clinician to infuse 500 to 999 mL per hour continuously using that medication entry instead of the bolus entry. We hoped the soft alert would drive use of the bolus entry for boluses and the infusion entry for infusions. Surprisingly, despite the high monthly alert rate, we proactively discovered this through analysis of the gateway data. We hadn't had a single report or mention of how often this alert was firing from any other sources, including our frontline staff. The technique used here was a soft limit exceeded report from the gateway, which is where most of our active surveillance starts. We export the report and start by pivoting raw data by drug and the total alert count. We then target and investigate drugs with higher alert rates. This find was early in our efforts to use data to target alerts. The first time we looked at a list of most frequently alerted drugs, the IV fluid entry was at the top of the list. For visualization, we then wanted to know what a better threshold might be to set the upper limit, and quickly realized the challenge was with higher rates. We could visualize the cumulative alerts by infusion rate, and the target became to increase the upper limit to 999 mL per hour. While the pump upper capable limit is 999 mL per hour, we knew we couldn't resolve those, but most of the other alerts here above 250 mL an hour could be eliminated by increasing the upper soft limit. We also wanted to reach out clinically to both confirm the infusion was often being used to complete boluses and to solicit feedback from actual users on why. What we found was that boluses are typically one-time orders, often followed by start of maintenance. To use the bolus button, the user would first have to enter a rate that may or may not make sense, especially if no maintenance was to follow. This is when we realized that the actuality of practice wasn't aligned with the thought process behind the library build. But we still wanted to understand safety. We also looked at the historical event reporting specifically related to IV boluses and didn't find any reports over a 4-year period since we started using this pump. Finally, we leaned on feedback from other institutions and found that many had encountered this issue and had successfully expanded the upper soft limit to 999 mLs an hour without an issue. Once diligence was completed, we recommended increasing the upper soft limit of this entry to 999 mLs per hour. Next is our cyclic TPN entry, which was affected due to a policy change as well as resulting EHR misalignment. There are multiple interesting points on this one. We had actually already identified the lower soft rate limit of our TPN entry on a previous analysis. The lower soft limit was firing frequently for our neonatal population. We had previously lowered it with a positive result, but then the cyclic TPN found itself on our list of potential targets again. A key takeaway here is that the same drugs can have multiple issues and can be affected by different contributing factors. It's important to be vigilant and proactive and regularly looking at your reports to see what new issues arise. The cyclic TPN entry came back up during routine surveillance because a policy changed that ultimately ended up affecting the run rates on our cyclic TPN orders, particularly in oncology. TPN often has compatibility issues with chemotherapy and other adjuvants. By default, most cyclic TPN in our organization was programmed to run over 18 hours, but oncology nursing requested flexible windows where appropriate run rates could be changed to create more line time for other therapies. The request was reviewed and approved clinically, and order sets were even adjusted in the EHR, but the change wasn't communicated all the way through to the pump team. Shortly after the policy and the EHR changes went live, the cyclic TPN entry started appearing on our list where it never had before after we corrected the lower limit. This opportunity was identified through active surveillance of gateway reporting. Using the soft limit exceeded report, after noticing the alert count had started to be high again, the targeted drug was pivoted by care area. This allowed us to see that something was different in oncology. We were able to take this information and reach out to oncology stakeholders, and that is when we learned about the policy change. Based on the new policy, we recommended increasing the upper soft rate limit to 250 mLs per hour. Now we're going to review the case of propofol, where the drug library was actually too complex to support appropriate drug selection and use. Like many of these interventions, this was discovered through active surveillance of the gateway reporting. Propofol was one that consistently came up in the top 10 when we looked at drugs from the soft limit exceeded report with the most monthly alerts. It wasn't immediately clear why the alerts were firing, so we had to flex this data a little bit more. We isolated propofol and first pivoted by care area. We could immediately identify the overrides were predominantly in the pediatric anesthesiology care area. To further understand what may be happening, we created a stacked bar chart by override type. We wanted to understand the pain points. We could see the pediatric anesthesia overrides were for upper dose limits and upper weight limits. We then looked at the care area limits. In pediatrics, the care area weight upper limit was set to 40 kilograms, meaning a warning or fire anytime a patient exceeds 40 kilograms for a weight-based entry. At the drug level, propofol had a dose limit of 200 micrograms per kilogram per minute. We reached out to our anesthesia providers to determine how the limits were set. We already knew that dosing recommendations for general anesthesia in pediatrics can reach upper limits of 300 micrograms per kilogram per minute. We needed to understand if there were additional reasons for the existing build. We learned that the intention is for the provider to switch to the adult care area when the patient exceeds 40 kilograms, which is why the pediatric area dose limit was left at 200 micrograms per kilogram per minute. In theory, it seemed like a good way to add safety by limiting the entire care area, but in practice, as personnel turnover and trainees come and go, the knowledge was getting lost. When we reached out to anesthesia to clarify and obtain the history, we only identified 3 anesthesiologists in the group that we met with that remembered how the build was intended to be used. We were comfortable recommending both an increase to the pediatric upper weight limit for the care area to 50 kilograms and a dose limit increase for propofol to 300 micrograms per kilogram per minute. Finally, an example of practice colliding with policy. Occasionally during this process, you will find that the alerts represent an opportunity for protocol compliance monitoring. For us, the drug was norepinephrine, specifically our library entry for peripheral line infusions. In our health system, we have both central and peripheral infusion policies for vasopressors. Peripherally, we allow use for up to 24 hours and limit the maximum rates. This helps support the Surviving Sepsis campaign effort to not delay vasopressor use due to lack of a central line, while also minimizing the risk of tissue damage due to higher rates and prolonged use in a peripheral vein. We also identified this alert starting with our soft limit exceeded report. It not only was consistently in the top 10 overall alerts, but we knew the overall alert rate was 101.4%, meaning alerts were firing multiple times per infusion. This isn't surprising with a titratable medication, as the rates can change frequently, creating more opportunity for alerts and alarms. When we selected this one to investigate, we had been following the monthly override rate for a while. We knew the alert rate was over 100% and the override rate was high. We could also see from the soft limit report that the soft limit alerts were for upper dose limits. We connected with nursing representation across the system and learned that most of the alerts were occurring at the start of the infusion. We consistently heard our frontline staff describe how patients didn't typically respond to the initial protocol rates or even the protocol titration schedule. They knew the central line protocol allowed for higher rates, so they would start at higher rates or titrate by larger amounts to achieve patient response, then quickly back off the infusion to the peripheral line limits. According to the feedback, they only needed to run the higher rate for a few minutes, and then the patient would suddenly respond, and they could pick back up on the intended protocol. The pharmacy team immediately honed in on priming and catheter volume. We realized that while the line would be primed, once connected to the patient, the remaining volume to the bloodstream still had to be accomplished before the drug would actually enter circulation and exert its effect. We, as the drug library team, already knew that no line priming feature was in use in our library or in our pump system. This is because we have multiple tubing vendors, multiple pumps, and standardizing priming volume is not possible for us due to the variability of supply at any given time. Our nurses were essentially titrating up so rapidly, they were inadvertently delivering bolus doses to close the gap from the connection through the remainder of the catheter to circulation. The sudden response they consistently described was likely the moment that the drug actually entered the bloodstream and started to exert its effect. We were seeing this with the peripheral entry because the rates and titrations were lower, smaller volumes, slower rate. It was taking more time to close that gap from the line connection to the end of the catheter. On further discussion, we found there was no policy or process for allowing a carrier fluid to assist with getting an appropriate dose into circulation in a reasonable amount of time. We found inconsistent practice. We also found no existing EHR orders or guidance for use of a carrier fluid or the use of maintenance fluid to help carry the drug. On review by our safety team, the idea of delivering larger potential boluses of vasopressor was not very well received. Literature indicates that patients who are started on higher doses of vasopressors often have a longer length of stay and require more pressor support than similar patients started at lower doses. This was not a practice we wanted to support or encourage. We recommended education on the use of carrier fluids with EHR support through administration instructions and linked orders for carrier fluids if patients didn't already have maintenance fluids orders, so that they could have something to serve as a carrier to help get that drug into circulation faster without needing to start at high rates for a vasopressor. So this was an opportunity for us where we found there wasn't compliance with a protocol, and we had the opportunity to proactively put education and EHR support out there and then monitor it moving forward. But once you've identified your potential opportunities, there's still a lot of work that has to be done. In our system, after an opportunity is identified, we have a clinical pharmacy team consisting of senior specialists like myself for each clinical practice area. We have EHR analysts and members of our drug use policy team. This group will do an initial review of any drug library optimization recommendation to assess protocol issues, safety issues, and feasibility. If this group determines the recommended optimization is viable, the senior specialist will identify other clinical stakeholders in nursing, specialty areas, and the pump event task force to take the recommendations outside of pharmacy for feedback and consensus. This group will help understand any practice preferences, history, as well as previous events associated with the identified optimization. Finally, once we have clinical stakeholder consensus, system stakeholders are notified for any final decisions and sign off. This process can take many forms depending on the size and scope of your organization, but it should involve all of your subject matter experts for any area that would be affected. It is important to have collaboration as it fosters ownership and accountability. This is also a great opportunity for students, interns, and frontline staff who are looking for additional opportunities and new learning experiences. We've identified opportunities and developed recommendations, and we've implemented change. How do we know if it worked? Well, there are a few different standing metrics you can follow that should change as your library is optimized. Let's take a few minutes to review those. First, the alert rate. What percentage of your infusions have alerts? Keep in mind, like we saw with the norepinephrine, this can be above 100%, which would indicate alerts are firing multiple times per infusion. It is good to keep up with the overall alert rate as well as the individual alert rate for library entries that you have optimized. If your change has targeted a nuisance alert, the rate should go down. If, however, you wanted to strengthen your alerts to avoid patient harm, the rate could increase, and that's okay. That means it's working. Next, the override rate. If you have reduced the nuisance, the override rate should decrease as the information being presented should be useful and be indicative of real alerts that should be addressed. Keep in mind the override rate only applies to soft limits. Hard limits can't be overridden. If you have changed a soft limit for a hard limit, like we did for boluses, you will want to start following the change in your hard limit alert rates. We also track the time to alert dismissal. And there is an asterisk here, so I want to take a pause and explain. This is the only metric that I will talk about today that is not readily available from gateway reporting. This is the time from when the alert fired to when the clinician cleared the alert on the pump, whether it was an override or a pullback. How long did they stop to read and process the information that was presented? Because we have data warehouse integration with our gateway, we do receive every keystroke and can report this. I've included it here because I want to show you how we have noticed this number change in the hopes that it will encourage you to seek to reduce nuisance alerts in your system. We will see the results for each intervention on the next slide, but our internal data shows that as we reduce alerts, the time spent on the alert and assessing the alert increases. When we started this project, the overall time to alert dismissal was less than 2 seconds. Currently, the overall time is near 6 seconds. It may seem minor, but that is 3 times longer that clinicians are stopping to process the information that is being presented. In combination with reduced override rates, this metric seems to indicate that clinicians are more likely to respond appropriately to alerts when they are not overloaded and fatigued with them. You should also follow safety event reporting through your voluntary error reporting system for drug entries that you have optimized. You want to ensure that the rate of reported events is not increasing. For example, with our IV fluids, increasing the max rate on the infusion to allow for bolus rates. We want to make sure that there are no reported incidents of fluid overload or prolonged continuous boluses. Finally, solicit feedback and continue to look for opportunities for feedback. Follow up with the teams and stakeholders you involved during the decision and implementation process to understand the frontline impact. So let's take a look at how these metrics played out with the optimizations we reviewed. Looking at the top line for the bolus hard limits, We implemented those in June. So you can see there is a month on the alert rate that does not exist. That was a washout from us because we switched from monitoring soft limit breaches to hard limit attempts. So there's some variability before and after, but overall, there's only an increase of about 15 alerts per month. The goal was to increase the effectiveness of the alert and to avoid patient harm. So we are okay with this. We did also see an increase in self-reporting of clinicians who were unable to enter the bolus they wanted, typically because they were attempting to use the calculated dose rather than the ordered dose units. We consider this a win as the alert is preventing the potential errors identified. Looking at IV fluids are where we actually started to reduce nuisance alerts as an organization, averaging 2,400 per month prior to the optimization, and now down to about 250 per month. It's important to note that we did not actually change the upper rate limits in our neonatal intensive unit care area, as daily fluid requirements are closely monitored and fluid overload is a high risk. The alerts we still see with our IV fluid entry are predominantly from neonatal infusions. And again, we are okay with that. That wasn't a target area for us. The override rate has also drastically decreased, which makes sense as there would be no more soft limit alerts in care areas outside of the neonatal ICU. For cyclic TPN, the bar chart is useful for showing how a policy change will affect your alerts. You can see that there were a base level of alerts that clearly spiked right there in the middle. That was June, July, and August when the policy went into effect. And then we addressed it and implemented a change in September. And you can see that the alert rate immediately drops. I will also point out here, because I've listed the actual interventions that were put into place for a cyclic TPN, we recommended to set the upper limit at 250 mLs an hour. But when our TPN team had the opportunity to review the recommendation, they recommended 220. They had their reasons, they had some evidence, they didn't want to exceed that for the rates, but we still may need to revisit this because while the overall alert rate has gone down, you can see that it started going down, the override rate has remained steady and actually increased a little bit. So we still may be missing the mark there, and we may need to get all of these players back in the room and discuss. But something else that was really interesting, and I'll point out because we did mention it, the time to override. This is one of the optimizations we did where the time to alert dismissal increased the most. Clinicians are reading and processing the alert. They're still choosing to override, and that's probably because the TPN team recommendation of 220 mLs per hour just isn't consistent with what's allowed in the EHR. And they're probably still having issues with EHR and pump misalignment. But you can see they are thinking about it. They are taking that pause and they are taking that extra moment, which we are very pleased to see. For propofol, we had actually recommended 2 optimizations, both an increase in the weight limit for the pediatric anesthesia care area, as well as an upper dose limit increase to 300 microgram kilograms per minute for propofol. We were only successful in getting the dose limit increased, which did help with the alert rate. But given the override rate has remained steady, it indicates that clinicians are still having trouble with this level of complexity in the library. We did see an increase in the time spent analyzing the alert by user, though. Finally, for the norepinephrine, we implemented education on the use of carrier fluids, 24-hour MAR reminder for central access, and linked carrier fluid orders for patients who didn't have maintenance fluids. The alert rate decreased, meaning they are not engaging in the rapid titration practices often due to the use of carrier fluids. Currently, we are following the overrides that are occurring and generally see that these patients are titrated appropriately but continue to decompensate, requiring a high level of care. So our goal now is focusing on how can we help clinicians identify faster that they're going to need the vasopressor beyond 24 hours, and we need to start trying to get a central line. In general, though, what we are pleased with here is the additional pauses to evaluate alerts. We do think this is the result of the overall decrease in alerts, getting closer to that recommendation to minimize nuisance alerts so that real alerts will be appropriately acknowledged. We did reduce alerts. They may still be a nuisance, but our frontline staff are pausing for longer than they ever did before. We've learned so much from this project that we now carry forward with us as we implement new build. It's important to track those metrics and use the data to verify the impact of your optimizations. This is also good for high-level awareness by your system stakeholders. These metrics are straightforward, and as you become familiar with how the metrics should change with your interventions, you can predict which way it should go if the change is effective. I cannot stress enough how important follow-up is. Monitoring your metrics is very important for ongoing process improvement, but the full picture includes touch bases with your frontline users, continual feedback from your safety team, and your educators. Lean on the factors that contribute to alerts that we reviewed at the start of this webinar. Consider them as you move forward with new build and anticipate where they may creep in to create nuisance alerts. Armed with the knowledge about why these alerts occur will help you prevent them from happening. Finally, communication. We've used this specific pump for our large volume infusions for 5 years. And over that time, the pump team has steadily built relationships across our system with groups ranging from the C-suite to clinical engineers and everyone in between. You can also develop and advertise channels of communication. For example, we have a generic mailbox established for any and all pump queries. Anyone at our organization can send an email to smartpumps@ynhh.org, and we will make sure it gets to the right subject matter expert. We also make resources available as appropriate, including access to the current drug library report so that clinicians can see the programs and the limits. Metrics on drug error reduction system programming and as well as auto programming compliance are also available, as are overall alert rates and override rates. We have found that frontline staff are more engaged if they are informed and if they know stakeholders are interested in paying attention. I think I kept you waiting long enough. I've talked about the what, the why, and how, but does it work? This is calendar year 2024. We started implementing these optimizations with IV fluids in April, and you can immediately see the difference, which only continued to improve throughout the year. At the bottom, you see the overall alert rate again, where we started above the national average and are now well below, averaging about 3.9% versus the national benchmark of 7.3%. We've decreased our overall alert rate by more than 60%, representing more than 30,000 annual nuisance alerts that have been eliminating. So check on our 50% goal. At the top is the override rate, which you can see has also decreased from that 82 to 83% range to the 58 to 60% range, and is also now below the national average of 66.9%. Since we know our overall time to alert dismissal has also increased, we do believe this represents frontline staff pausing to evaluate the alerts and respond appropriately because they are not inundated with alerts as often. We believe this trend supports that alert fatigue is very much real, and that by reducing nuisance alerts, clinicians can be more receptive to the alerts that they do see. So the key takeaways for us. We can learn so much from our own data. Taking a look at a few reports will quickly identify where many of your alerts are firing, but it often takes more investigation to understand why they're firing. It is critically important to understand the factors and mechanisms that are driving your alerts and to determine if they are a nuisance or if they are necessary. This always takes a multidisciplinary approach. You may need to gather the history of why the alert was developed, if there have been policy or practice changes, and the effect on safety. Use your subject matter expertise available in your organization to develop the full picture and work together to implement effective optimizations. Thank you all so much for your time today. I'm going to hand it back to Sammy now.
Thank you so much, Kim. Congrats to you and your organization for all of the work that you've done to optimize the library and effectively reduce your alert burden. I think you really highlighted the importance of balancing those safety alerts with nuisance alerting. So thank you so much. This screen is just a reminder about our medical education website. Feel free to scan the QR code. We are always updating our resources on there, so feel free to check that out. Kim, I do have a few questions for you after listening to the presentation. The first one on your implementation slide, one of the system stakeholders mentioned was a smart pump committee. Could you talk a little bit more about who's on that committee, how often they meet, and kind of the role they have in the process?
Sure. We actually have multiple smart pump committees. We have a system-wide smart pump committee stakeholder meeting that is a quarterly meeting. That includes a lot of chiefs. We have our chief nursing informatics officer. We have some chiefs from our digital and technology services. We have executive leadership from pharmacy, and then we have subject matter experts from the EHR team, nursing education, drug library, multiple stakeholders from across the system. So this is our comprehensive team where anything pumps is evaluated. So this, for example, is the group that reviews when we want to implement a new technology. We'll review those RFPs for appropriateness, set the tone, and establish the standards that we use in our pump technologies across the system. So they follow safety events. They follow large oversweeping general trends, such as our alert rate, our drug error reduction rate, and they kind of set the tone for how we do pumps across the system. We do also have smaller pump committees. So, for example, there's an internal pharmacy smart pump committee, and these are your drug library stakeholders. We actually meet weekly to review any pending drug library changes and any education and associated, reach outs or cross-functional collaboration that needs to happen. So there are a few different committees that happen, but our system smart pump committee, that is their role and their function.
That sounds great. It's nice that you've been able to get all of those stakeholders in one place because, as we know, pumps touch so many different disciplines. So that's awesome. And then one other question for you. I think it's great that you continued to trend the data after you implemented a change because I think often it can kind of feel like, oh, I made the change, kind of set it and forget it. I'm curious how long after that implementation do you typically trend for?
I think the idea, and we're not even a full year out from some of these changes yet. So I think at least 1 year. And then what we will do, we do have a rolling log of the changes that we've implemented, just so we know what we've done. It's on our project management board that we've tracked. So what we will do is continue to do our monthly and quarterly surveillance monitoring, and we can always reconcile it with the changes that we've made and say, oh, IV fluids have cropped up again, let's figure out why. So I think our goal loosely right now, it's not completely determined, is to follow for a year, make sure the trend is steady and settled out, and then go back and revisit and potentially repull that data if the drug that's been intervened on does pop up on our list again.
Got it. I think that's great. And I think one of the examples you highlighted that you had changed something, then there was a new policy that brought it back up to your list. So I think kind of highlights how fluid everything can be and so many systems that have to communicate with each other. So
it is an active process. I will say that it requires proactive and active surveillance. And just because something has been addressed and investigated does not mean that it won't come back up. And it could be for a different reason. So these are dynamic systems, dynamic organizations. So you have to be, on the lookout at all times.
definitely. Well, thank you again, Kim. This was such great information. And thank you to tuning in. We look forward to seeing you on another webinar.
Thank you, everyone.